Hello, everybody, and welcome. I am Dr. Natalie Crawford, a board certified OBGYN and REI, and today I am happy to be joined by Dr. Heather Huddleston, who is one of my colleagues. She's also a board certified OBGYN and REI, and she's a professor at UCSF, and she does a ton of clinical research. We are here today because you may be aware I posted a video about a progestin IUD and some clinical observations that I was seeing, just calling them to light. And one of the things that I brought up was that we didn't have data on this specific topic, which is the potential development of scar tissue inside the uterus, so intrauterine adhesive disease in IUD. We haven't studied that yet. And Dr. Huddleston reached out to me because this is something they actually have been studying and currently are studying at UCSF. And we thought this would be a good time to talk about what data does exist and what does not, and what we're still gathering, just in the spirit of facts, evidence-based medicine, and women being able to make informed decisions. So Dr. Huddleston, thank you so much for joining me.
Great to be here.
What made you want to study this? What was the catalyst to say, is there a connection between the progestin IUD and potential intrauterine adhesive disease? What was that first question, or what led this?
Yeah, I think it was a question that just really evolved over the past few years where my colleagues and I started to just feel like we were seeing a pattern with intrauterine adhesions and maybe it being linked to progestin IUD, but we really weren't sure. And we really wanted to check ourselves and say, are we just imagining this? Are we just sort of seeing a really unique population? Is it just that so many more people are using the IUD that's why we're just seeing more of this crop up and there's actually no association? So we just saw this as an opportunity to learn more and wanted to learn more. And often I had patients who really wanted to learn more. I had patients who specifically asked me about this and said, "Aren't you studying this? Why can't someone study this?" So to some degree it was our own curiosity, and some of it was the patients asking us for more information.
Before we dive into the data that you have collected, I had a lot of questions in the comments about why the progestin IUD specifically. So do you want to explain why that's different than, a non-hormonal or a copper IUD, why there's this extra question around the progesterone IUD or the progestin IUD specifically?
Yeah, so the progestin IUD releases a hormone, progestin or levonorgestrel, at really high concentration into the uterus, and that causes the lining to change in a way that becomes very thin, very atrophic, and that's why a lot of patients with the IUD will not have periods while they're using it. And it's one of the really nice features, quite honestly, of it. And especially for people who struggle with heavy periods or painful periods, it's great at addressing that. But it does have this change to the lining, which has always been presumed to be reversible as soon as the device comes out. The copper IUD does not release hormone. It's actually just serves as sort of a foreign body in the uterus, and that's how it works as a contraceptive. But it doesn't really change the lining or the biology of the lining or how the lining is growing during the cycle, during the time of use. So there was some biologic plausibility for us that with these changes that we're seeing in the lining, if that lining hadn't recovered or if an insult happened to that lining when it was so thin and atrophic, could that be a setup for maybe why some scar tissue could form? So there was this sort of subtle, associations that we were maybe seeing with our patients that we were curious about. There was some biologic plausibility there. And that's what drove the question. But I do think it's important to call out for patients out there that so far there has been no signal around the copper IUD and these questions.
So it's the really thinking about the function of the endometrium, that we know there's, these two different layers. There's a basal regenerating layer, how I like to explain it, and then this functional layer that we bleed. And we know from non-IUD literature, from, uterine trauma and other data, that when you damage that basal layer, that's when we tend to see a higher predisposition to scar tissue. So you're saying because the functional layer is thin or gone, potentially there's biologic plausibility that that basal layer could get damaged or may not regenerate, or that we might have some higher risk.
Yeah, I mean, I think there's still a lot with the biology that we need to understand. But Estrogen is a very important hormone for endometrial growth and regeneration and healing. And so that's something we know and we've seen. When you have a high level of progestin in the uterus, it's really down regulating the estrogen receptors. It's really blocking the effect of estrogen. So, one way to think about it is that the lining really is in a state where estrogen can't do its normal
Job.
growth and healing job. And so if an injury does occur during that time, is the lining in its normal state where it's able to heal the way we know that often the lining can heal, even when there are injuries to the basal layer? We know that often the body can heal that. When you have a C-section,
Right.
that heals because the uterus knows how to heal itself. It has a lining that's very good at that. But in a state of where it's exposed to a certain level of superphysiologic hormone, the question is it able to do that in the same way? That's what we want to learn more about.
That's a great point, that it's not just high progesterone, kind of normal estrogen, that the action of this high and this prolonged progestin is causing almost an anti-estrogen impact inside the lining. So it's really changing the function of the lining too, not just thinning it or making it go away, but the function of it.
Yes, I think it's definitely something functional. I do think, interestingly, there's a lot here to learn, quite honestly, because we know that uterine adhesions are such a challenging problem for our patients. And all of this has also made me realize we need to just learn more about the healing and regenerative capacity of the uterus. If we understood that better, quite honestly, we'd be better at treating uterine adhesions. I
Yeah.
think we're still a little bit in the dark ages there. Hopefully, all of this conversation will, I think, hopefully motivate more research around all of these questions.
I hope so. I think all of us who, are infertility specialists, we know how difficult Asherman's or intrauterine adhesive disease can be sometimes for patients, that it's not always just a remove the adhesion and the situation is done. Sometimes it's multiple surgeries or many failed transfers, and it can be quite a process. So, to your point, understanding more about the functionality of the endometrium and how it regenerates and what can promote that or not really are core clinical questions we don't have full answers to that we need to answer. Let's talk for a minute about the publication that you have that is not yet, it's in preprint stage, but this is intrauterine adhesions and prior use of a progestin releasing intrauterine device. Do you want to explain how this study was set up?
Yeah. So before I do that, the study, just to sort of be transparent, we
Yeah.
haven't we're submitting it for publication hopefully this week, but it has not been peer reviewed. Some of the data was submitted as an abstract to the ASRM meeting this past year. It was presented as a poster. So some of our data and findings have been out there in the world and in the public record. So I do feel okay about speaking in general terms about it.
Mhm.
But I'm really excited about when this project does get published, so we can really talk even in more detail
Yeah,
about everything in the publication. Right now, I do want to let the peer review process unfold the way it should to make sure we have the best possible
of course.
data in the world. But the study to just sort of set the stage. When you're thinking about a possible association that you're seeing clinically, you have to think like, how can we prove this? How can we learn more about it? So with this particular question, the easiest and quickest way for us to get an initial signal was to think about a case control study. So when you do a case control study, you're looking at your outcome first. You're saying, here's my outcome. Here are my patients who have adhesions. And I'm going to look at the type of exposures they've had over time. And then I'm going to compare them to a control group of people that I think are really similar to them, but just don't have uterine adhesions. And I'm going to see, do they have those same exposures or is there something different? So to do this, we went through 6 years, and I had a whole army of amazing medical students help do this, but we went through 6 years of hysteroscopies that had been done at our center. So procedures where we went in with a camera, looked into the uterus for a variety of reasons, and we pulled out every single case where uterine adhesions were identified. And we also then had to figure out what is our control group. So when we got our adhesions, we had over 300 people who'd had adhesions over this period of time.
That's a lot.
Yeah, it was a lot.
You guys are a big
Um,
center.
we are a big center and we see patients are referred to us, for this particular issue. So I do want to, highlight that too, that, we are seeing a very distorted group because we're seeing sort of some of the worst cases coming to us. So we've got that group. We looked at how frequently these patients had used an IUD in the past, a progestin IUD specifically, as well as other contraceptives. We looked at a lot of things. But when we looked at progestin IUD, it was around 30% of the patients had used that type of IUD. So then we said, well, is that what does that mean? Is that high? Maybe that's what most patients are using,
Mhm.
who are similar to this group. So we had to come up with a control group. We actually did two different control groups. Our first control group was people who had also had a hysteroscopy, but who had a diagnosis of an endometrial polyp, which is a overgrowth of the lining. And we thought would be a really good control group because they also had a hysteroscopy, but they just didn't have adhesions. They had something else. Interestingly, with that group,
Yeah,
we found an incredibly low rate of IUD use. We saw only 3% of those patients had had a progestin IUD, which from there we concluded that's actually probably too low. And the progestin IUD probably prevented polyps, kind of
right.
to this
You said the
idea.
general population's a little higher than that, and so
Yes, we knew 3% was not right. So then we said we have to get another control group. So then we went through all of the same period of time, that 6 years of time. We went through patients who came into our clinic for just a new patient consult who had a diagnosis code of either unexplained infertility or male factor infertility. And from there, we did a select group at each year, taking 100 patients because we wanted to make sure we were using the same amount of time. Had about 700 patients who came in for that reason. When we looked at prior IUD use in that group, we found it to be 11%, which
okay.
is probably similar to what we see in population studies. There are different studies out there. There's some that suggest it might be a little higher in some populations, even maybe up to 14%. But 11% for us felt real in terms of what probably is out there in the population. But I think what we can say, at least from this initial this is just the most broad look at this. This is before we even set up sensitivity analyses and controlled for confounders and things like that. But what we see is that there's probably a threefold more likelihood of having use of progestin IUD if you have adhesions compared to people who don't have adhesions. So this for us was enough of a signal, and it was a very strong signal, very low p-values, to say this is an association worth studying more. There's
Yeah.
something here. We can't prove causation, but there's something going on, and women deserve, for us to be able to get more to the bottom.
And there was was there a difference in some of the, when you looked in the sensitivity groups about certain groups of people that appeared to have a stronger association than others? Is that something you feel comfortable sharing at this time
Yeah,
about how you felt about that?
yeah, I can sort of share more generally a theme that we saw that I think is really important.
Mhm.
Is that we saw really this effect, this association, much more strongly and at a high odds ratio in women who had used the progestin IUD for over 5 years. When we looked at the group who had used it for fewer than 5 years or 5 years and less, the association was really almost not even there. And so this to me is also, first of all, it's somewhat suggestive of causation because you have a dose response.
Right.
Um, it also is to me very interesting because it flags the fact that we've started using the IUD in ways that it wasn't necessarily studied from a fertility standpoint. So we're starting to use it for 7, 8 years. You have many of my patients have used it for 12 years. They've
Right,
had
they've
three
gotten 2
IUDs.
IUDs. Mhm.
Yeah. And when you look in the literature, that pattern really hasn't been examined. And so that's where we were seeing a high concentration of the effect and the high odds ratio. We also saw it more in nulliparous women, so women who had not yet had a baby. And so I think we need more numbers there to really know what's going on with
Why?
Paris women. And is it just that maybe it's more the duration of use that's part of this? But it did seem, if I were to sort of generally summarize the pattern we're seeing, is that there is an effect. There's this link here, and it seems most prominent in long-term users and women who haven't had a child.
And I think that's really important just, to know as we're talking about counseling, because to your point, practice patterns and behavior have changed over time. And we don't always have as robust data in that group to feel really confident in what that means long term for at least for the uterus, the endometrial lining, or, for fertility, to put it in a one line sentence. And this data that you've gotten now that will be, published and we'll share it, but it was the catalyst for you then to get a grant and to be enrolling for a prospective study, correct?
Yes, so it's a small internal grant. I wish I had more funding for it, but and I also
Always
have
for
some
women's health.
always. I actually also had some donations from some of my patients actually who were motivated around this being studied. So we pulled together enough funds, and my fellow actually got a grant from PCRS. So we pulled together funds from a bunch of different places to launch a prospective study to look at this question. So as we mentioned, we did this case control study. It showed an association. What we cannot say from our data, unfortunately, and very frustratingly, is that for any individual woman, I cannot tell them what is their chance of this outcome
Happening.
happening, right? It could be 1 in 1,000. It could be 1 in 100. It could be 1 in 50. We don't know. And the only way to know that is to develop a prospective study where we take women, users and non-users of these contraceptive methods, and we follow them for a few years and we track what happens to them and get an understanding of what is the actual risk. Did this outcome happen to people in our prospective study, and how many of them had it happen? And um, there are a couple prospective studies out there around progestin IUDs that have been done by Lauren Wise's group, but they looked at conception rate and they looked at miscarriage rate. Um, and it looks reassuring, but there's just some caveats there. One, they just don't look sort of a little longer term of like, if you do have a miscarriage, what happens? Or, are there any other sequelae? They also don't necessarily have a large population of women who've used the IUD for a long period of time. And if you look in some of their publications, it looks like the majority of patients had used it only for a few years. So I do think there is a big gap in the data around long-term use and what
Right.
happens. And that's why we really feel like this prospective study is looking at a question that has not been answered by the existing literature and is really critical to getting the information we need for women.
We're definitely going to share the link to the prospective study because if you are trying to get pregnant, have used contraceptive, it's not just the progestin IUD, but any type of contraception in the past, right? You can enroll no matter where you are living. And it's essentially filling out surveys over the course of a year, I believe, where you're reporting, what is going on.
Yep. Yep. So we're looking at, and people who've been either just started trying to get pregnant, or you're about to start trying to get pregnant. You've been trying for just a few months. And then, yes, we need people who've used the IUD, but we also know people who didn't, because we need to be able to compare, right? So we need
Right.
both. And we're recruiting all across the country. It's just some surveys. Essentially, there is reimbursement for your time. And right now we're planning it for up to a year, but my guess is that we're going to want
It's a
to
long time.
extend it. And that will be sort of especially as we're able to get a little more funding, because I do think we need to just really follow this out and know what's happening beyond just a positive pregnancy test.
I agree. And I think for, maybe younger women who don't know this, right? As practice patterns have changed, we now need the data to catch up. Because when I first entered the field, nulliparous or women who'd not had a baby before, the progestin IUD wasn't an option to them for contraception. And the progestin IUD was only used for 5 years. So now, as it's FDA approved to be used longer, we are offering them to nulliparous women, which is a wonderful, very effective contraceptive option. We need the data to know what potential, risk or side effect. It's all about informed consent so that you can know what this might mean for you and not have women sitting across from us who we probably have both seen, who just said, I had no idea that this could potentially happen,
Yeah.
uh, that are driving us to study this. And the study is called the Fertile Study, correct? Fertility, reproductive outcomes, and time to conception, the impact of long-term IUD exposure. And we'll put the registration link there. And we really encourage everybody to share that with, your network on social so that we can drive up, registrants. Because for a prospective study, which is going to give you the, the listener, the clearest indication of risk, the more enrollment, the higher the number that enroll really drives how, fine tune we can see what that risk will be. So the study that exists right now that you have that we will put when you're ready to share the preprint, we will, is showing an odds ratio. So just showing strength of an association. As you said, it's not truly showing causation, even though there's some suggestives that the longer term use was more significantly impacted. This study, the prospective study, is what we really need, right? So when I said we don't have data on this and I'm concerned about it, and you say, well, we do have some data, you're still concerned about it. So now you're doing, more of a definitive study with this prospective, the fertile study, to try to answer what the risk is for an individual woman.
Yeah, exactly. And I think you're right that the reason you don't start with a prospective study is that it's harder to pull off because you do need a lot of people to enroll, because we know this outcome isn't going to happen to many of our patients. Many of our patients are going to be totally fine. So in order to get an estimate, you need to enroll a lot of people. And that's why getting the word out around the study would be super helpful because in order to get this answer, we need people to participate. We need, quite honestly, hundreds of women so that we can get an estimate of risk. And I agree with you. It's all about informed consent. I mean, the oral contraceptive, which we all prescribe, has risks. It has a small risk of blood clots. We tell people about that risk. We give them numbers around that risk. It's such a low risk that most people feel comfortable moving forward with it. So we need that kind of data around this outcome. And I think being able to give those numbers to women so they can make a decision. And perhaps in this study, we can also learn maybe there's safer ways to use this contraceptive. It's an excellent form of contraception. As I shared with you before, I allowed my daughter to get it. But maybe there's ways, that we just haven't realized are causing problems. Maybe there's something about duration. Maybe there's something about when you remove it. We just don't know. But if we can get this data, my hope is that we say this is a great contraceptive, but we need to use it in certain ways in certain patients
Yeah.
in order to protect fertility.
Guide clinical management more. And I think to that point, one thing I think that is important to know is that there isn't much study done on long-term IUD use. So in women who've used an IUD for 5 years or more. So if somebody's saying this is perfectly safe, there's been a lot of research done on it. What do you say to that question?
Yeah, I mean, honestly, I thought that was the case too. When I started seeing these patients that were having these issues, I was like, this can't be true because we were all told it's completely safe. Fertility is perfect after you remove it. And I was like, I thought that this was really backed up by evidence. When I started planning this project and going back in and looking at all the studies that have been done, there were some studies that looked at fertility for when they were looking at the IUD for use at 5 years, which was how it was initially approved. When it was extended to 8 years, there was a trial of women who were in the study who were using it for 5 years, and they let them go to 8 years, and they looked at the contraceptive efficacy. And then they said, it looks like it's a good contraceptive even up to 8 years. And then they said, well, there's been a few people in the study who stopped before 8 years and tried to get pregnant. And we're going to look at them and see if their fertility rates are good. If you look at that study, it was 31 women in the study who tried to
31.
get pregnant. And I think some of them did. They did not necessarily follow them past the point of
Long-term.
positive pregnancy rate. But what it was surprising to me is that we approved it for contraceptive efficacy for 8 years, but we really didn't, I don't think, do due diligence around is fertility still okay at 8 years? That question just hasn't been looked at.
Well, hopefully you are leading the charge so we can get that data to answer that question and then to be able to provide clinical guidance around how to use it, recommendations for removal or length of duration, and things that we just don't have right now. What lasting message do you want to leave? Because I do want to say you and I are not anti-contraception. We love hormonal contraception as an option. We want women to have more options in their toolbox when it comes to preventing a pregnancy or getting pregnancy, whatever works for them. We just want women to be making these decisions from a place of data and knowledge. And what do you want to leave people with knowing?
Yeah, I 100% agree. I think we would want to leave people, first of all, with to what, as far as we understand right now, the IUD is probably safe in the vast majority of women. I would not encourage people to remove their IUD. If you're considering IUD, I would still get one. We are at the same time working really hard to get more information so that we just have a little more specificity in what we're telling patients. And so I think, know that we're trying to do this work. Please spread the word that we're trying to do this work. And it also flags, I think, for all of us to remember that women's health really has been under researched
Yeah.
compared to a lot of things. And this is honestly just another example. So I think if there's anything for us all to unite about, it's that we need to demand better research for women's health across the board, not just this issue.
Amen to that. Thank you so much, Dr. Huddleston, for joining us,
You're welcome.
for sharing your research with us, for sharing it with the world, for being so passionate about researching not just this, but all the topics that you do research to ultimately help women understand their bodies, their health, and their decisions better. And we'll be sharing the links to the prospective, the fertile study, in the show notes here and all over social media so that women can share and enroll so we can get this more definitive data. Thank you.
Thank you.